You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about left ventricular assist devices. In this part 1 of a 2-part series, we'll talk about patient selection for LVAD, including reasons for LVAD placement, LVAD components, LVAD physiology and troubleshooting, and LVAD complications. So let's jump in with reasons for LVAD. There are 4 possible roles that LVAD can play in a heart failure or heart transplant patient. One is bridge to transplant, BTT. That's for patients awaiting heart transplantation. 2 is destination therapy for patients ineligible for heart transplantation but eligible for LVAD. LVAD can be the permanent placement. 3 is bridge to recovery. That's temporary support for potentially reversible heart failure. And 4 is bridge to decision, temporary support while evaluating candidacy for further interventions such as heart transplant or durable LVAD. According to the 2023 International Society of Heart and Lung Transplantations (ISHLT) guidelines for mechanical circulatory support, long-term durable mechanical support for patients who are in acute cardiogenic shock should be reserved for the following. Class 2A. A. Patients whose ventricular function is either deemed unrecoverable or unlikely to recover without long-term device support. B. Patients who are deemed too ill to maintain normal hemodynamics and vital organ function with temporary mechanical support devices, or who cannot be weaned from temporary mechanical support devices or inotropic support. C. Patients with capacity for meaningful recovery of end organ function and quality of life. D. Patients without irreversible end organ damage. Patients who are inotrope dependent should be considered for durable mechanical support, as they represent a whole group with high mortality with ongoing medical management, Class 2A recommendation. Patients with end-stage systolic heart failure who do not fall into recommendations 1 and 2 above should undergo routine risk stratification at regular intervals to determine the need for and optimal timing of durable mechanical support. This determination may be aided by risk assessment calculators and cardiopulmonary stress testing, Class 2A. If anyone's interested in cardiopulmonary stress testing, you can listen to the next episode where I describe the details of that CPAT testing. Heart failure patients who are at high risk for 1-year mortality using prognostic models should be referred to advanced therapy, including heart transplant or durable mechanical support, either bridge to therapy or destination therapy as appropriate, Class 2A. Selection is based on INTERMACS profiles. Recall the 7 INTERMACS profiles which we described in the cardiogenic shock episode. INTERMACS 1 is critical cardiogenic shock, crash and burn. INTERMACS 2 is progressive decline, sliding fast on inotropes. INTERMACS 3 is stable but inotrope dependent stability. INTERMACS 4 is resting symptoms, frequent flyer. INTERMACS 5 is exertion intolerant, housebound. INTERMACS 6 is exertion limited, walking wounded. INTERMACS 7 is Advanced New York Heart Association Functional Class 3 placeholder. Specifically, recall what INTERMACS 1, 2, 3, and 4 are. INTERMACS 1, which is critical cardiogenic shock, crash and burn, describes life-threatening hypotension despite rapidly escalating inotropic support, critical organ hypoperfusion, often confirmed by worsening acidosis and or lactate levels. INTERMACS 2, which is progressive decline or sliding fast on inotropes, describes declining function despite IV inotropic support and may manifest by worsening renal function, nutritional depletion, inability to restore volume balance. Also describes declining status in patients unable to tolerate inotropic therapy. INTERMACS 3, which is stable but inotrope dependent or dependent stability, describes stable blood pressure, organ function, nutrition, and symptoms with continuous IV inotropic support or a temporary circulatory support device or both, but patient demonstrates repeated inability to wean from support due to recurrent symptomatic hypotension or renal dysfunction. INTERMACS 4 describes resting symptoms or frequent flyer. These describes patients who are stabilized close to normal volume status but have daily symptoms of congestion at rest or during activities of daily living. Doses of diuretics generally fluctuate at very high levels. More intensive management and surveillance strategies should be considered, which may in some cases reveal poor compliance that would compromise outcomes with any therapy. Some patients may shuttle between INTERMACS profiles 4 and 5. INTERMACS 1, 2, and 3 are inotrope dependent, whereas the rest are not. INTERMACS 1, 2, and 3 are the NIHAR Class 4 non-ambulatory patients, whereas INTERMACS Class 4 and Class 5 are NIHAR Class 4 ambulatory patients. INTERMACS 6 is NIHAR Class 3B, and INTERMACS 7 is NIHAR Class 3. 23 MCS guidelines from the ISHLT say INTERMACS profile 1 to 3 patients benefit in terms of survival from implantation of an LVAD, Class 1 recommendation. So, for those with critical cardiogenic shock, those who are sliding fast on inotropes, and those who are stable but inotrope dependent in INTERMACS profiles 1, 2, and 3 respectively, they will have survival benefit from LVAD. INTERMACS Profile 4 may benefit in terms of survival from implantation of an LVAD, but that's a slightly less strong recommendation at Class 2B instead of Class 1. In other words, patients with resting symptoms, frequent flyer, who are stabilized close to normal volume status but have daily symptoms of congestion at rest or during activities of daily living may have survival benefit from LVAD. For INTERMACS Profile 1 patients, which is critical cardiogenic shock, clinicians may initially choose temporary mechanical support devices such as Impella or ECMO before transitioning to a durable LVAD. For patients with INTERMACS Profiles 2 to 3, which is sliding fast on inotropes, dependent stability and inotropes, respectively, early LVAD therapy is often recommended to avoid complications that arise from prolonged severe heart failure or shock. Delaying LVAD implantation until a patient reaches INTERMACS Profile 1, which is critical shock, is associated with worse outcomes. You gotta do it at INTERMACS 2, 3, or 4. Regarding comorbidities and selection, the 2023 MCS guidelines from the ISHLT say, if possible, permanent durable mechanical cardiac support should be delayed in the setting of an acute infarct, at least 5 days, Class 2B recommendation. Durable mechanical circulatory support may be reasonable in select patients with manageable peripheral vascular disease, Class 2B. They note that atrial flutter or fibrillation is not a contraindication to durable mechanical support, Class 1. Patients with medically refractory atrial arrhythmias may benefit from ablation of the arrhythmia or AV node with subsequent ICD or pacemaker placement before LVAD implantation, Class 2B. Patients with treatment-refractory recurrent sustained ventricular tachycardia or ventricular fibrillation in the presence of untreatable arrhythmogenic pathologic substrate such as giant cell myocarditis, SCAR, or sarcoidosis, a biventricular support or total artificial heart is preferred over isolated left ventricular support, Class 2A. Consideration of durable mechanical support in the setting of irreversible multi-organ failure is not recommended, Class 3. Now, let's move on to understanding the components of an LVAD. There are several types of LVADs. There's continuous flow devices, which are the most commonly used devices today, such as the HeartMate 3 and HeartWare HVAD. These use centrifugal or axial flow mechanisms. There's also pulsatile flow devices, which is an older technology that's less commonly used now. This episode will focus on the HeartMate continuous flow device because that is the one that I have seen the most. But you're of course welcome to check out the device information from any manufacturer. This is not biased in any way. A left ventricular assist device, LVAD, contains of an inflow cannula, pump cover, lower housing, screw ring, motor, outflow graft, and pump cable. The inflow cannula is surgically inserted using a coring tool into the left ventricular apex and secured by sewing an apical attachment cuff to the epicardium. The outflow graft is surgically anastomosed to the ascending aorta by an end-to-side anastomosis. What exactly is happening? The LVAD is a centrifugal pump. Blood from the left ventricle is drawn into the inflow cannula along its central axis and is expelled at right angles by and between the impeller blades of the rotor rotating about the central axis. The rotor works by magnetic levitation, so it is not susceptible to the mechanical wear and tear that mechanical or fluid bearings are. The pump cable, which is permanently attached to the lower housing, supplies electrical connection to the enclosed motor. The pump cable is tunneled through subdermal abdominal tissue via a tunneling tool and exteriorized through the skin wound that is created by a skin coring punch. Once the pump cable comes out of the skin, it is extended by a modular cable which connects it to a system controller. The pump cable plus modular cable is what we refer together as the driveline. The driveline plugs into the system controller, which is the interface device on the outside with all the buttons and alarms. The system controller receives power from the power module, the mobile power unit, or portable batteries. What I described here, again, is for the HeartMate 3, but variations will exist according to manufacturer and device, so I encourage you to check those out at your convenience. The HeartMate 3 can operate in pulse mode, which means that once every 2 seconds, the pump modifies its speed to generate an artificial pulse. This artificial pulse beats 30 times per minute, asynchronously with the heart's actual beat. Now that we know the components of the LVAD, we need to understand several important concepts in LVAD physiology. If we don't understand these concepts, it'll be hard to troubleshoot when error messages come up. These concepts are speed, flow, power, pulsatility index, a PI event, and triggers of pulsatility events. Let's start with speed. Speed refers to the revolutions the pump is making per minute, RPM, revolutions per minute. Speed can range from 6,000 to 15,000 revolutions per minute and is more typically set at 8,000 to 10,000 RPM. When people say fixed speed, they are just referring to the fact that speed is a variable that is set by the clinician. The clinician also sets a low speed limit, typically 400 to 800 rate revolutions per minute, below the fixed speed, to specify the lowest speed we allow the device to operate. On the main screen of the LVAD console, what is displayed is the actual pump speed. The actual pump speed should be within 150 RPMs of the fixed speed. During a suction event, the device speed drops to the low speed limit, then ramps up to the fixed speed, unless another pulsatility index event is detected, in which case the device drops to the low speed limit again and ramps back up. In situations where there is no pulsatility index event, failure for the device to keep up with this fixed speed can indicate a pump, percutaneous lead, or controller issue. Next concept is flow. Flow, which is measured in liters per minute, can range from 3 to 10 liters per minute. Flow is the ratio between the rotor speed and the difference in pressures of the inflow and outflow cannula, also called the pump head pressure, or H. This tells you that flow through the LVAD is inversely proportional to the difference in the left ventricular pressure and the aortic pressure. While power and speed are directly measured, flow is a calculated value linearly estimated from power, which can underestimate actual flow at high flows. If there is a device thrombus, that causes increasing power requirements without causing actual greater pump flow. So the calculation of flow based on power will overestimate the flow. A flow of less than 2.5 liters per minute is an emergency. The next important concept is power. Power, which is measured in watts, is a function of speed and flow. If flow is high, then power is also high because it takes more work to move more blood. If flow is low, then power is also low. Similarly, if speed is high, then power is high. If speed is low, then power is low. If power gradually creeps up over hours or days, that may indicate thrombus deposits inside the pump or aortic insufficiency. Depending on the speed of the pump, sustained power spikes above 10 or 12 watts may indicate intermittent resistance to flow from a developing thrombus. If the power gradually declines, that may indicate an obstruction of flow. Overall. Now, the next important concept is the pulsatility index, or PI. When the left ventricle contracts, the increase in LV pressure increases the pump flow during cardiac systole. The magnitude of these pulses of flow are measured and average over 15-second intervals to produce a pulsatility index. The PI attempts to convey the degree of pump power variability, representing pump flow variability and ultimately native heart contractility. Specifically, it is a ratio comparing the maximum power to the minimum power differential compared to the average power. Pulsatility index can range from 1 to 10 and is more typically between 3 to 7. The magnitude of the pulsatility index is related to the amount of assistance provided by the LVAD pump. Higher PI indicates more ventricular filling and higher pulsatility, meaning the LVAD pump is not needing to provide as much support to the left ventricle. Conversely, lower pulsatility index indicates less ventricular filling and lower pulsatility, meaning the LVAD pump is having to provide greater support to further unload the left ventricle. PI should not vary significantly during resting conditions. If there is a significant drop in PI, that could indicate a decrease in circulating blood volume. What is a PI event? A PI event refers to a sudden change in pump flow pulsatility of at least 45% of the PI average over the preceding 15-second interval. PI events may be due to orthostasis exaggerated by hypovolemia or vasodilation, or arrhythmias leading to poor ventricular preload. PI events may also result from suction events that occur from transient septal contact with the inflow cannula or from acute proximal device occlusion. When a PI event occurs, it is assumed to be a suction event, so the heart rate 3 will automatically slow down to the low speed limit to improve preload. All suction events are PI events, but not all PI events are suction events. What are triggers of PI events other than suction events? These can be sudden changes in a patient's volume status, as I mentioned, arrhythmias, including atrial fibrillation, as I mentioned, sudden changes in pump speed or power, ventricular suction, coughing or sneezing, beat-to-beat variations in LV volume, or the use of an intra-aortic balloon pump. How do you think about pulsatility index in patients with hypertension? In patients with hypertension, the minimum and average flow are lower, resulting in low flow and high pulsatility index, more than 10. What about pulsatility index in a patient with a balloon pump? In diastole, the balloon pump inflates the perfused coronaries, which results in a higher afterload and lower pump flow. In systole, the balloon pump deflates, resulting in a slightly higher systolic pump flow. The systolic to diastolic difference results in a higher, more than 10, and more variable pulsatility index. This may trigger a lot of PI events. What about pulsatility index in patients with aortic insufficiency? In aortic insufficiency, increased preload increases the minimum flow during diastole. We will see a low pulsatility index, generally 1.5 to 2.5. In addition, estimate flows appear higher for a given speed. To summarize, when there is high variation in the flow, i.e. high pulsatility index, we should think about hypertension, severe hypervolemia, arrhythmias, orthostatic changes, presence of a balloon pump, transient flow occlusions, or early tamponade. When there's low variation in the flow, i.e. a low pulsatility index, if flow is low, we should think about late tamponade and sustained flow occlusion. If flow is high, we should think about aortic insufficiency. That is my overview on LVAD physiology and interpretation. Now, in this last third of the podcast, in this episode, we will talk about LVAD complications. Overall, the LVAD warfarin INR goal should be 2 to 3 plus aspirin. DOACs are generally not used for LVAD due to insufficient data at this time. If you see tea-colored urine, power spikes, since power equals flow times resistance and thrombus increases resistance, heart failure symptoms, high LDH, consider an LVAD thrombus. If unclear, you can do a RAM study, which I will describe at the very end of the next episode. You can place the patient on heparin and consider a pump exchange. If you have GI bleeding, which occurs in 1/3 of LVAD patients, transfuse and scope per GI recommendations. If there's lots of chest tube output that stops, drop in blood pressure, increase in RA pressure, consider tamponade. Check the echo for RV compression, and consider bringing back to OR for exploration of the mediastinum. If there's a drop in blood pressure and increase in RA pressure, but the RV is dilated on echo, then consider RV failure. Give inotropes and consider RVAD. If neurologic changes are present, consider stroke. Do a head CT, and you may need to reverse anticoagulation if there is ICH. If there's purulent discharge, consider a driveline or LVAD infection. You may need to do a pump exchange if the pump is involved, and antibiotics, of course. Let's see what the 2023 Mechanical Circulatory Support Guidelines from the ISHLT has to say about these complications. Starting with thrombosis. For diagnosis, the initial evaluation of suspected device thrombosis should include laboratory tests such as lactate dehydrogenase, hemoglobin, and plasma-free hemoglobin to assist in the diagnosis of intravascular hemolysis and hemoglobinuria by urinalysis and to detect end organ dysfunction. That is a Class 1 recommendation. The initial evaluation of suspected device thrombosis should include device interrogation with manufacturer log file analysis to assess pump parameters and changes over time, Class 1. The initial evaluation of suspected thrombosis should include an echocardiogram to assess for LV unloading with and without speed adjustment, i.e. a ramp study, Class 1. In patients with a high suspicion for device thrombosis, CT angiogram to evaluate the outflow graft is recommended. What about the management? Initial management of patients with confirmed device thrombosis should include intravenous systemic anticoagulation with heparin, Class 1. In patients with confirmed device thrombosis who are candidates for surgery, pump exchange is the definitive therapy, Class 1. In patients with confirmed device thrombosis who are hemodynamically stable and expected wait time for heart transplant is short, it may be reasonable to defer the pump exchange for urgent transplantation, Class 2A. In carefully selected patients supported by a hydrodynamic centrifugal pump with confirmed device thrombosis, systemic or intravascular thrombolytic therapy can be considered as an initial management strategy over device exchange, Class 2A. It might be reasonable to choose bivalirudin over heparin as an initial agent for intravenous systemic anticoagulation, Class 2B. In a heightened thrombotic proclivity of patients with recurrent pump thrombosis, exchange up to a HeartMate 3 from a prior device may be reasonable, Class 2B. Now, let's see what they have to say about bleeding. Bleeding is a common problem. How do you manage it? Anticoagulation and antiplatelet therapy should be held in the setting of clinically significant bleeding, Class 1. Anticoagulation and antiplatelet therapy should continue to be held until clinically significant bleeding resolves in the absence of evidence of pump dysfunction, Class 1. The patient, device parameters, and laboratory markers of hemolysis should be carefully monitored while anticoagulation and antiplatelet therapy are being withheld or dose reduced, Class 1. Once the initial mucocutaneous bleeding has resolved, anticoagulation and antiplatelet therapy should be reintroduced with careful monitoring of patient hemoglobin and stool, Class 1. Repeated endoscopic evaluation may be reasonable in durable mechanical circulatory support patients with recurrent gastrointestinal bleeding episodes, especially if poor therapeutic targets were identified. However, in patients with recurrent negative endoscopic evaluations, the utility and benefit of repeated endoscopy and/or angiography is likely low. That's a Class 2B recommendation. In a setting of recurrent mucocutaneous bleeding with no identified source or a source that is not amenable to therapy, it may be reasonable to lower warfarin anticoagulation goals or amend antiplatelet therapy. Adjustments should be reevaluated in the context of bleeding severity, pump type, and complication history to derive an individualized patient risk to benefit ratio, Class 2B. The use of subcutaneous or depot octreotide may be considered in patients with recurrent GI bleeds, Class 2B. While low pulse pressure driving LVAD support is associated with development of arteriovenous malformations, bowel wall ischemia, and mucocutaneous bleeding, the effectiveness of pump speed reduction in patients on continuous flow pumps in reducing bleeding has not been well established and may be harmful, Class 3. I will leave out the sections on stroke and infection since the diagnosis and management of these conditions are primarily driven by existing stroke and infection guidelines in that specialty. Outflow graft obstruction can result from graft kinking or twisting and can result from graft thrombosis or external compression. Management: surgical indication is indicated in patients with documented hemodynamically significant outflow graft obstruction, Class 1. Percutaneous treatment approaches are reasonable to consider in select patients with documented hemodynamically significant outflow graft obstruction, Class 2B. How about blood pressure management in LVAD patients? To reduce the risk of stroke in hospitalized patients, it is reasonable to target a mean arterial pressure of 75 to 90 millimeters of mercury in LVAD patients, Class 2A. There is no data to support aggressive afterload reduction after LVAD implant. Excessive pharmacologic hypotension with a MAP less than 75 millimeters of mercury should be avoided. Class 3. Now let's talk about ventricular arrhythmias. Ventricular arrhythmias occur in 1/3 to 1/2 of LVAD patients. Ventricular arrhythmias of short duration are often tolerated in patients on LVAD support. If cardiac index or index device flow remains above 2 liters per minute square, mean arterial pressure is more than 65 to 70 millimeters of mercury, and end organ function is preserved, urgent cardioversion may be delayed in favor of less aggressive interventions. Patients with signs of hemodynamic instability or those with prolonged ventricular arrhythmia should undergo electrical cardioversion to avoid end organ compromise or LVAD thrombosis. Is cardioversion safe in LVAD? Repeated cardioversions have been associated with acute reduction in right ventricular function, but LVAD dysfunction directly attributed to electrical cardioversion has not been reported. So that's useful to know. What do the guidelines say from the ISHLT about management of ventricular arrhythmias in LVAD patients? In LVAD patients with hemodynamic instability, as evidenced by low MCS flows, signs of new or worsening RV failure, acute kidney injury, symptomatic hypotension or hypoxia, due to new onset ventricular arrhythmia, urgent cardioversion or defibrillation and or anti-tachycardia pacing is recommended. That's a class 1 recommendation. Patients with new ventricular arrhythmias post-LVAD implantation should undergo LVAD interrogation and echocardiography to assess for the possibility of suction events, class 1. In patients who are hemodynamically stable in a new ventricular arrhythmia post-LVAD, it is reasonable to try electrolyte optimization and intravenous antiarrhythmic therapy before electrical cardioversion. An ECG should be obtained to capture VT morphology. Prolonged, more than 30 minutes VT-VF in patients on isolated LVAD support should generally be avoided regardless of hemodynamic stability, class 2A. Patients with refractory hemodynamically unstable ventricular tachycardia may require catheter ablation. Catheter ablation should be performed by an electrophysiologist with experience in treating patients with DMCS, class 2A. Finally, we'll end this episode by talking about what to do during cardiopulmonary arrest in a patient with LVAD. According to the 2023 MCS guidelines from the ISHLT, in patients with a continuous flow LVAD, a mean arterial pressure of at least 75 millimeters of mercury usually provides adequate tissue perfusion. In patients without an arterial line, use of a Doppler for blood pressure assessment may be required due to the limited accuracy and precision of current automatic blood pressure devices, class 1. Defibrillation may be safely performed in patients on LVAD support who are in unstable arrhythmias, class 1. So don't worry that you are defibrillating metal. This is actually safe in patients with LVAD, according to the guidelines. Unless advanced directives state otherwise, cardiopulmonary resuscitation, CPR, with chest compressions is generally advised in unconscious patients on isolated LVAD support without evidence of adequate and LVAD complications. Stay tuned for the next episode where we'll talk about the part 2 of LVAD issues, focusing on imaging. We'll talk about pre-LVAD echo assessment, post-LVAD echo assessment, and ramp study.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.